So actually, some of this we've already kind of touched on, so I can sort of zip past some of these things here. Our cohort at Cincinnati, so this is the most, I've shown this graph now since I think 2016 is when I first made it, and I've been updating it. This was updated about a week or two ago. So this is through sort of 3/4 of 2019. So we've seen 27 patients at Cincinnati that I would say are in this SJIA lung disease spectrum. That excludes a couple patients that we've seen because of concern, like they had some clubbing, but we weren't able to find anything on CT or anything else. Excludes some patients that don't really have SJIA, but have kind of a similar looking lung disease. They don't have anything that looks like SJIA, like they don't have a rash, they don't have arthritis. It's hard to call it SJIA. So there's a couple patients that are kind of excluded for this because they don't really fit in there well. And so you can see that we've been seeing somewhere between 5 to 10 new patients a year over the last couple of years. Most of these are patients who were referred to us after diagnosis for sort of second opinion or for concern for lung disease. As Alexi mentioned, there had been 5. When we did this number, there were 5. Now we have a 6th from our patients here. At that point, we had about 74 or 75 patients that we considered actively following. This was based on some work that my former fellow Shimi Yazin was doing, which that would imply something in the sort of 5 to 7% prevalence in our local cohort. As you see, 20 of these 27 were seen since 2016. So our paper that came out described 18 patients, so we've seen 9 since we wrote the first draft of that paper in the fall of 2018. So of those 9, as I said, 1 is a newly diagnosed local patient. The other 8 were referred or transferred from outside for evaluation. Our most recent group has a sort of a slight female predominance. The 18 had been equally 9 and 9 boys and girls. The median age for this new group of SJIA onset was about 18 months old, of lung disease was about 2. All of them had been on biologic treatment prior to detection of lung disease. All of these new 9 ones had a history of MAS, and 8 of the 9 had clubbing. Tissue biopsies were on 4 of the 9. One of them did die, and the lung disease actually wasn't diagnosed as such until autopsy. So this is the characteristics, some of the characteristics from our cohort that we published, but then this last column here includes these 9 more recent patients. Most of the trends are sort of pretty similar. Again, age of onset of the underlying disease in the neighborhood of 2 or a little bit under. Lung disease a couple years later. The MAS frequency has gone up with these more recent ones. Again, I think that the older the cohort gets, I think the more heterogeneous it is, because I think, as has been kind of alluded to by Dr. Grom and others, before the pre-biologic era, there were kids who had pulmonary hypertension with sort of just very prolonged systemic disease activity, but then once that could finally be treated with something effective like biologics, then that kind of resolved. And so I think you have a bit more of a gemisch of disease in the older cohorts, where if you kind of restrict it to those in the last several years, it's been a very clear and striking phenotype. Again, biologic exposure, the very high IL-18, and this is the measurement most proximal to when lung disease was detected. Again, about 10% or so of them have trisomy 21. As I said, and now 1 of the patients we've seen has died, unfortunately. This is from our paper, looking at some of the risk factors that we found. So this was a small case control study that Dr. Yazin did, matching those lung disease patients by age and sex to ones that we follow in our registry. So we have a sort of them very well phenotyped and characterized. What she found was that those with lung disease were significantly more likely to have an age under 2 at disease diagnosis. Were significantly more likely to have had MAS in the past, were more likely to have had some sort of a reaction to biologics that required them changing therapy. Most of them were these sort of bizarre tocilizumab reactions that we've talked about, but some of them had been like hepatitis in response to anakinra, which Dr. Canna actually wrote the first report of. I always forget that. Back in the old days. And then higher IL-18. What's that? It's just a case report. But it's like the only thing in the literature on it. But, and then higher IL-18 in those who have lung disease. And then again, looking at the age a little bit more granularly, again, this bottom is the controls. This is what you're going to see in the textbook if you read, if you read Fabrizio's chapter in the Cassidy book. He says it has a broad peak of incidence from sort of 1 to about 10, and then it kind of trails off into the adult world, and we start calling it Still's disease at some point. Whereas those who have lung disease have a very strong clustering in that 0 to 2 range, and then a few later. This is, again, the table from our paper. Again, it has a lot of the data on here, but the thing I want to point out is then this last column here of sort of the outcome. And so what we did for this was we talked to the physician who sort of knew them the best on both the pulmonary side and the rheumatology side, and said, overall, since lung disease diagnosis, how do you think they've done? Do you think they've gotten better? Do you think they've gotten worse? Do you think they're kind of about the same? And you can see there's a wide variation in that. Some of them, a number of them were, people said they've clearly improved. Several, they're clearly had worsened. Many were kind of in that, yeah, I don't know. I guess they're kind of stable, but I'm not really sure in the middle. But definitely some have gotten better. So I wanted to talk about one of them. So this is, so Dr. Grom actually misspoke. Our first lung disease patient actually comes from the early 2000s, and we forgot about this patient because, as you'll see, they actually did so well that their primary rheumatologist, one of our partners, kind of forgot they had lung disease because they had a lot of other ish, and then the lung disease got better. So this child was diagnosed in the early 2000s. So originally diagnosed at the age of 3 with a classic SJIA picture. Had fevers, had a typical rash, had polyarthritis involving the ankles, wrists, knees, fingers. Had MAS, was hospitalized for MAS at presentation. This was in 2004, I believe, maybe 2003. We have a file where we have dictated notes to refer to PCPs that I can search. So I found notes from Brent Graham, who's now at Vanderbilt, who diagnosed this child back in 2003. So it was treated initially with steroids, because that's what we had, right? And then cyclosporin for the MAS was later changed to Tacro. Every time, every time they tried to go down to the steroids, flared, had subclinical MAS with very high liver enzymes, very high soluble IL-2, persistent hepatomegaly, along with having a lot of GI issues, just GI pain, diarrhea. They tried IVIG, which helped some, but really unable to wean the steroids. And then in about mid-2005, then they started on anakinra and really had very dramatic improvement. However, then about a year or so later, the child developed clubbing. Had an outside chest x-ray that was concerning for ILD, and so we got a CT, which is, of course, still in our computer, and it was read as having irregular thickening of the interlobular septa, peribronchovascular interstitium, subpleural tree and bone opacities, reticular opacities, exactly the pattern that we see in most of the patients that we're seeing. And they didn't know what to do about this. Clinically, the child was okay, didn't have really respiratory symptoms aside from the clubbing. But had a lot of other issues, right? Was having these continued GI issues, significant growth failure, both because of the disease, but really had been unable to wean steroids really for the entire disease course. Was ultimately found to have this sort of bizarre GI enteritis MAS. Actually, they did endoscopic biopsies, and you could visualize MAS in the sort of the GI lumen of this child. Yeah, histiocytic expansion. Exactly. Yeah, it was bizarro. So ultimately, was able to go up, increase the canakinumab and the Tacro, which helped, but again, never able to come off steroids. Tried tocilizumab, but had a reaction. This is, of course, IV tocilizumab. Continued to have active arthritis, and then was ultimately started on canakinumab. And on an increased dose of canakinumab and then a little bit of methotrexate, was able to wean off steroids after 8 years of chronic steroid use at various levels. The lung disease, as I said, the primary rheumatologist kind of forgot about the lung disease because it wasn't really a clinical problem, and it was secondary to all this major stuff, this enteritis, this growth failure, this steroid dependence, as well as some various family and psychosocial issues. Never had any clinical concerns. I think they saw Lisa Young once when she was still at Cincinnati, but then it kind of faded away. The clubbing gradually resolved. I saw this child last year, and I couldn't appreciate clubbing, and neither could Dr. Tao. And we finally got a repeat CT, which was 12 years after the last CT. And it said, interval improvement in appearance of lung parenchyma, just mild residual interstitial thickening. And this is a couple images from the CT. So this is the original one in 2016. Again, you can see these sort of air bronchograms, this sort of septal thickening. And this is the one that we got last year, which honestly looks pretty darn good. So we treated this child's lung disease, but we have no idea how. What we did do, ultimately we're able to control the child's underlying disease. So we're able to get ferritin normalized. Really, all of our disease biomarkers were able to be normalized. Once we're on effective levels of IL-1 blockade, as well as the TACRO, the liver inflammation resolved. So I think if there's a lesson, it's that the underlying disease was able to be treated. It was TACRO, yeah.
She also changed her gender. I don't forget that part.
Yeah. I don't think that's related. But yes, she's a he, which complicates things. But
Actually, it's somewhat relevant to that. In your larger group, did you see any difference between sexes in outcome? Like, in the few patients we've seen at the NIH,
yeah, that's a great
boys did
question.
much worse than the girls?
It's a great question. Right, right. I don't think so. No, I don't think so. I'd have to look at that more carefully.
We're not a big IL-18 infection, right?
No, we didn't. The most recent one was in the normal range. Yeah. So what do we do for this? So this is kind of what we do now. This is the spiel that both Dr. Tao and I give when we see patients for newly referred for this. Things that we think but don't know are helpful. So the first one is preventing lung infections, which sounds good. So I think we can all kind of agree that lung infections are bad. So we give prophylaxis, which we say is pneumocystis prophylaxis, but probably prophylaxis for other opportunistic infections. And then aggressively treating lung infections. And again, some of the sicker patients, when they have lung flares, they've seemed to respond to IV antibiotics. But we think that lung infections definitely can flare things up and make things worse. The biggest thing really is controlling that underlying disease activity. I think we see patients who, they say like, well, I'm not having fevers, I don't have arthritis, I never really had much arthritis, but I had a little bit, but now it's gone. My skin rash is gone, so the disease is well controlled, right? But as people were saying earlier today, but the ferritin is still 500 or 1,000, and some of these other biomarkers that Scott mentioned, IL-18, S100s, are still quite high. So I think the disease in many of these patients is not fully controlled. And so we think that trying to get that under control, if we can, is helpful. And then thinking about, can we do things for this pulmonary inflammation? Because when we look at these biopsies, and we look at this interstitial component that Dr. Grom mentioned, when we looked at it with some of our pulmonary pathology colleagues, they say, it's not dissimilar from what you see in other connective tissue-related ILDs. Like this alveolar proteinosis component is very different, but this interstitial inflammation, you see things that look sort of like that in RA-ILD, and like, what do you do for that? Like, well, you give them something like Cellcept or Tacro or things like that. So T-cell targeted therapy. There's trials for abatacept in RA-ILD. So thinking about something that's going to target that lymphocytic inflammation. Dr. Tao likes azithromycin, which has sort of these vague, fully uncharacterized anti-inflammatory properties, probably doesn't hurt. Inhaled corticosteroids, which again, we've talked about that. He's used that, I think, in 1 or 2 patients, but again, there's concerns about, is it actually getting where it needs to go? Probably not. These are the things we do, and again, it's too soon to tell, I think, whether these are effective, and I think that's where the role for a sort of a longitudinal, careful following of these patients, so we can try to understand, what's helping, what's not helping, and what's the natural progression of this disease, because we don't really have that, and we don't really know. I think that's my last slide. Yeah. Just thanking all these people, so yeah. See, right on time. I'm right on time. Right, yeah.
Just to follow up on the comment that you made about the gender reassignment issue, and Raphael's comments about androgens. Virginia as well just recently showed data about estrogen signaling and its role in SJIA. So
Its role in what?
SJIA.
SJIA.
So again, the issue of think out loud about the role of sex steroids in moderating the disease, especially it's more for discussion.
Yeah.
Maybe we have the other.
Yeah, I think that's an interesting thing to think about, especially, given the relatively young age of onset. Again, we're seeing this more in younger children than in older patients. Although, there are patients who have adult Still's disease who are getting lung disease. I'm not entirely clear whether it's the same lung disease or whether it's different. But there are adults who are getting this sort of lung disease as well.
Yeah, so Virginia, I was just trying to look at my notes from the release, but she actually showed some, again, it's protein expression, microarray, and stimulation, looking at the estrogen receptor signaling. So we were also looking at diet things, right? Because the whole idea of broccoli and all of those signaling through these pathways and other estrogen sources. So that was really the gist of it. But she only showed a couple of slides. I didn't dig into it.
It was protective also, what
It was protected. Yeah.
No, I think there is data out there that post-puberty there is a difference in terms of interferon signatures in neutrophils that is actually much less in boys than in men at that time than in girls. That you don't have that pre-puberty. So there used to be a steroid effect with interferon signaling. I think that was limited to type 1 interferon signaling, but I don't know if that would pertain to type 2 as well. Would be another thing. I mean, I think there are, this is getting more and more recognized. I mean, in mice it's been established for a while already, but the Diamond has done a lot of work in basically showing that female mice actually do much worse than any lupus models than mice.
I just have a question. Has anybody been able to identify any protective factors against lung disease? I mean, I'm just using our child as an example. She meets every single risk factor. For the last 18 months, her disease has not been well controlled, and yet she doesn't have any evidence. We've CT'd her. We've done an overnight pulse oximetry. Has there been any look into that? Is she just a ticking time bomb, or are these kids, there are some kids that just maybe have something that prevents it?
I mean, that's a fantastic question, and it's a really interesting one, right? Because, at least 95% of kids who are on biologics don't have lung disease. Even if you restrict it to those who've had MAS, or further restricted to those who've, have early onset, have high IL-18, it's still a minority of those kids. And so we don't know whether it's this geography question, is there something in the environment, whether it's microbiome or something else, is it genetic? There are clearly other factors that we don't have a clear grasp on that are either, as you said, exactly, either essential for driving this or are protective.
I want you to just touch out loud. So, like 10% of your cohort has Downs.
Yeah.
And there are at least two sort of thank you. At least two lung-related immunologic problems in folks with Downs. One, they have a interferon signature, which may have to do with the duplication of the interferon receptor and that chromosome 21. And they have a structural problem. Like kids with Downs aspirate more. They get all kinds of upper respiratory infections because of a sort of what you might consider an anatomic immunodeficiency. Do you have any more thoughts about that?
I think the Downs kids are different. I'm trying to remember. at least some of them haven't gotten the crazy clubbing, as Dr. Tao calls it. Some have had some clubbing. For some of them, their IL-18s are not nearly so high. Again, they're high, but they're not as crazy high. The pathology is the same. The CT findings are the same, but other parts of the clinical story are not the same. So and in fact, the child who died, when it came to us, had been diagnosed with systemic JIA at the outside. It didn't really feel a lot like systemic JIA to us. We didn't really know what exactly it was. The child never left our hospital, progressed, had liver failure and respiratory failure, died, and it wasn't until then biopsy that it demonstrated this exact features of lung disease on the autopsy, but didn't have sky-high IL-18s, never got clubbing, but was clearly in this family. So I think there are, and then Dr. Tao takes care of a patient who, again, pathology looks very, very similar, but doesn't have high IL-18, never had an SJIA, even SJIA-like disease. But there are other features that are very similar. So I think there's a number of ways you can get to this kind of lung disease, and I think Downs plus some other things gets you there. I think some other diseases can get you there.
Did the Downs kid have any myelomonocytic transient expansions? Because Downs are known to get those.
Right. No, they didn't. Mona?
You could tell parents to be able to find the stuff. Fever, pruritus. Fever, itching, some of these things that parents will notice
Yeah.
before the
Yeah,
ILD
yeah.
comes up. Obviously, the redness around their fingers.
Yeah.
Any of that you could.
Yeah, I think
advise them on?
those are really, I think, key. And I don't think, we need to kind of get that sort of prospectively in a cohort of patients, because it's, again, you have this sort of recall bias, right? That, you ask patients who have, parents of kids who have a terrible thing happen to them, you remember what your child was wearing when they were hit by a car. You ask me what my daughter was wearing last week, I have no clue, because she didn't get hit by a car, right? And so you don't necessarily remember those things because your child did well. So I think you need to understand this in a prospective way to figure out those kind of more subtle things like that.
So to piggyback on Kate's question, have you looked at patients that retroactively kind of check the box that Dr. Brown mentioned on the slide earlier, but did not progress to ILD?
We haven't yet, but we want to, yeah, and particularly looking at their immune responses, and then some of these biomarkers that Scott was talking about to see what's different, right? Because again, in the broad picture things, they fit the pattern, but clearly something is different. Bita.
Thank you. What I'm going to say is kind of half statement and then half question. We know that most of the illnesses that we deal with, more so in the adult world than pediatrics, are kind of multifaceted, multifactorial. So we have a genetic susceptibility, underlying disorders that kind of further that susceptibility at a more physiologic or pathophysiologic levels, and then we have triggering factors that kind of set off what happens. So to me, it makes sense why some kids do have all the risk factors, but maybe they haven't had that triggering point, et cetera, et cetera. Is that how, the factors that you have identified, would you say some of those kind of go into more of the triggering factor and more of some of them to like underlying more kind of associated, more predisposing factors? And if that's the case, then which one of them you consider towards which group?
I think that's a great question. So I think that these factors are not the predisposing triggers. I think they're basically the setup. And I think that they largely are grouped together as having bad SJIA or SJIA-like disease. Again, they have early onset, they have a lot of systemic features, they have very high IL-18. That then sets you up for something else. And then again, do the biologics, are they an accelerant? Maybe is that why this wasn't recognized nearly as much? But again, not the essential trigger, or they're essential, but they're not the trigger. They're an accelerant. These other things sort of set them up, and then there's something, whether it's environment, whether it's genetics, whether it's microbiome, whether it's something else, that is the necessary trigger. So that's what I think with zero evidence to support that. Maybe. So the GI doctors were convinced this child had just an separate autoimmune process. They said they have autoimmune enteritis, NOS, something. And then it was only when our pathologists, who again are used to looking at our BMT kids' biopsies with this HLH, our patients with MAS, went back and stained to specifically look for it, that they saw this just massive MAS-like process. So the question is how often this occurs. I don't think we know. This is, Alexi knows this patient much better than I.
What happened with the girl? She was admitted with a very, very difficult to treat MAS. And I remember we could not get decent levels of serum levels of cyclosporine, and she was having diarrhea. And there were reasons to worry about possibly CMV-driven process, and we were wondering whether, in fact, that CMV was sitting in the guts, or whether CMV-driven enteritis that was driving MAS. And because of the enteritis, she was not, that enterohepatic recirculation of cyclosporin was affected, and we could not get good levels of serum cyclosporin A. So that's the reason we went to scope her and did a biopsy. And the biopsy showed massive sort of MAS-like picture in the guts. Lots of CD8 cells, lots of hemophagocytic macrophages, and then that's when we switched from cyclosporin to tacrolimus eventually. And we got decent serum levels of tacrolimus. So that's sort of what happened there.
So were the scopes done when she was on or off steroids?
She was on steroids.
So I think if there's a take-home, it's that if someone is having really significant GI issues, there is a role for having GI see them and potentially getting biopsies to try to understand what's going on.